Hello everyone, and welcome to the Army of Women Researcher webinar series. My name is Nikki Larita. I'm the Research Manager at the Dr. Susan Love Research Foundation, and I'm thrilled to be hosting the session today. Before we get started, I'd like to thank everyone for joining us. Thank you, Dr. Greenup, for taking time to teach us about the work you've been doing. Also joining us today, we have Dr. Susan Love, our Chief Visionary Officer, and Leah Shragi, our Clinical Research Director. Today we're going to have a conversation with Dr. Greenup about the financial side effects of breast cancer treatment. This study launched in 2017 in a collaboration with the Army of Women. I'd like to take this opportunity to introduce our researcher. Dr. Rachel Greenup is an associate professor at Duke University. Her research has looked into doctor-patient relationships within oncology, high-value breast cancer care, and understanding how the cost of treatment impacts women with breast cancer. I have a few housekeeping items to cover about this presentation and the GoToWebinar platform. First, if you have any questions throughout the webinar, please send them to us through our questions tab, which is located at the side of your screen. We will have time at the end for questions, and we'll make every effort to answer as many questions as we can. Finally, a recording of today's webinar will be available on the Army of Women website within the next few days. With that, Dr. Greenup, you can start your presentation.
Well, thank you all for the opportunity to partner with you in research and also to share my findings. I'd like to call the title today "The Financial Burden of Breast Cancer Treatment." As many of you know, breast cancer remains a major medical and public health issue in the United States, with 1 in 8 women being diagnosed during her lifetime. It is the #1 cancer diagnosis and the #2 cause of cancer-related death among women in this country. At the time of diagnosis, women with breast cancer face multiple complex treatment decisions, and the decision about the surgical treatment of their disease can be one of the most difficult. Eligible women can choose between lumpectomy with radiation or mastectomy, and both long-term and contemporary data have consistently shown that these treatment options are equally effective, leading to equivalent disease-specific and overall survival. Therefore, the decision a woman makes about the surgical treatment of her disease does not necessarily impact her cancer outcome. These decisions are instead guided by patient preferences and recommendations from their cancer team, with consideration of many factors. Women consider recovery time, risk of recurrence, peace of mind, side effects and complications, need for future surveillance, appearance of the breast, in addition to variables that are personally important to them. However, currently, costs of treatment are not routinely included in the shared decision-making process, as women are weighing the benefits and potential harms of these equally effective choices. At the same time, healthcare costs continue to rise. Over the past 3 decades, the United States healthcare spending has risen to 18% of the gross domestic product. In 2015, the U.S. spent over 3 times on healthcare than other countries with comparable incomes, yet without seeing improvements in health, access, or life expectancy. The high cost of cancer treatment certainly contribute to high healthcare spending overall, and breast cancer treatment is an expensive part of this story. Currently, it makes up 13% of total cancer treatment costs and is estimated to reach $20 billion by 2020. Costs vary by stage, age, and phase of treatment. Cancer treatment costs are unsustainable for both the healthcare system and for patients themselves, and the financial harm associated with high cancer treatment costs is now known as financial toxicity. And more recently, the magnitude of this issue for patients is being unveiled. Average out-of-pocket expenditures for cancer patients currently approach $5,000 per year. 25% of cancer patients report using all or most of their savings to pay for treatment. About 40% of patients who have received chemotherapy report financial hardship related to their cancer diagnosis. And receipt of cancer diagnosis increases the risk of bankruptcy by 2.5 times. More recently, and more importantly, bankruptcy after cancer has been associated with an early risk of death. In 2009, the American Society of Clinical Oncology formally recognized the potential harm of high cancer treatment costs and recommended that oncologists discuss costs with patients embarking on treatment. These guidelines align with the Institute of Medicine's aim to promote patient-centered cancer care, in which empowered patients played a major role in their treatment decisions. To this end, we aimed to describe the financial burden of breast cancer care, to assess the role of costs in cancer treatment decisions, and to evaluate women's preferences for cost transparency. In conjunction with the Duke Qualitative Research Team, which consisted of doctoral-level survey methodologists, we created an 88-item survey based on previously validated and published question items that met our outlined aims. A critical part of our survey development was collaborating with patient advocates from the Alliance in Clinical Oncology Group and the Sisters Network of North Carolina. These were breast cancer survivors and volunteers who are engaged in academic research in order to ensure that our patients' perspectives are included in scientific work. Our survey was pre-tested in volunteers and then revised to incorporate all this feedback. We then approached the Army of Women and the Sisters Network of North Carolina for participation. As you all know, the Army of Women is a national coalition of volunteers engaged in breast cancer research, and the Sisters Network of North Carolina is an African American breast cancer survivors support group. Women were eligible for participation if they were over 18 years of age with a history of breast cancer living in the United States. Women received an electronic invitation with a survey link to participate, and only complete surveys were included in our analysis. Our participants included 654 women with a mean age of 58 years old. The majority had early-stage breast cancer and completed the survey a median of 6.8 years from diagnosis. 69% of women reported private insurance and 26% had Medicare. 56% reported an annual household income of greater than or equal to $75,000 per year. 44% of women were actively receiving treatment at the time of survey completion. 59% underwent chemotherapy. 62% underwent radiation. 94% underwent breast cancer surgery. And 34% reported undergoing breast reconstruction. Our first goal was to characterize the financial burden of breast cancer treatment and to better understand women's experiences with breast cancer treatment costs. In an attempt to better understand the timing of cost transparency, or when women first learned about the cost of their cancer treatment, our survey asked, when did you first start learning about the cost of your treatment? Although many women first learned about treatment costs within 6 months of diagnosis, only 27% reported hearing of these costs within 1 month. 69% of women reported their insurance covered between 80 to 100% of their breast cancer treatment costs. Despite this, 35% reported somewhat to catastrophic financial burden as a result of their cancer treatment. In addition, we found that 78% of women never discussed costs with their cancer team. 35% reported that treatment costs were higher than they had expected. The median reported out-of-pocket cost was $4,000. Yet 5% of women reported out-of-pocket costs over $40,000. Next, we assess financial burden based on surgery type. The dark blue represents women who reported a slight to somewhat financial burden related to their cancer care, and the lighter blue represents women that reported a significant to catastrophic burden. Women who underwent bilateral mastectomy, both with and without reconstruction, were more likely to report significant to catastrophic financial burden than those treated with lumpectomy. Costs of treatment and financial burden differed by surgery type. Although these treatment options were equally effective, we found that they differed in their risk of financial harm. The next goal of our survey was to assess the role of cost information in cancer treatment decisions in order to understand if women with breast cancer were thinking about or incorporating the cost of care when making treatment decisions. Approximately 1/3 of women reported considering costs when making surgical treatment decisions for their breast cancer. We then asked participants to prioritize the factors that contributed most to their surgical decision-making. As shown here, the survey included a long list of factors that we as physicians and surgeons routinely discuss with patients and their families at the time of diagnosis. These factors have been well studied and validated as important to women in the surgical decision-making process and include things as previously mentioned, like healing and recovery time, complications from surgery, sensory loss, need for future mammograms, feeling sexually attractive, and appearance of the breast. Women were asked to rate each factor from not at all important to extremely important on a 1 to 7 scale, and cost of treatment was embedded in this list. Women ranked opinions and advice from the medical team and fear of recurrence as the two most influential factors when making surgical treatment decisions. In the overall cohort, cost of treatment seemed relatively unimportant as women considered different factors. However, when we looked at women with lower household incomes, including those who had a household income of less than $45,000 per year, cost of treatment gained importance in surgical decision-making. More interestingly, cost of treatment became more important than factors that we routinely discuss, including everything to the right of the light blue bar: appearance of the breast, total time for treatment, loss of sensation, feeling sexually attractive, keeping all or part of the breast, mammographic surveillance, opinions from friends and family, and avoiding radiation. Next, women were asked to report their recollection of the estimated total out-of-pocket costs for their cancer treatment, which differs by surgery type. Median out-of-pocket cost for lumpectomy was $2,750. For mastectomy without reconstruction was $1,000 and was $6,000 for bilateral mastectomy with reconstruction. We then evaluated the importance of costs in treatment decisions based on household income. Again, on this graph, the lighter blue bar represents women who reported that they did not consider costs when making treatment decisions, while the dark blue bar represents women who did consider costs. The y-axis depicts percentage of women in each income bracket, and the x-axis represents annual household income, which ranges from $30,000 per year to over $150,000 per year. We found that $74,000 per year was the tipping point, below which women were more likely to consider costs when making treatment decisions, and above which women were less likely to consider costs. Interestingly, this dollar amount correlates with the point at which happiness is not improved with higher income. Further results demonstrated that younger minority women with private non-Medicare insurance were more likely to consider costs as part of surgical treatment decisions when compared to older white women covered by Medicare. Additionally, when costs were brought up during the clinical encounter, either by patients themselves or the medical team, women were more likely to include costs when making treatment decisions. Lastly, we evaluated patient preferences for cost transparency. In response to the comment, I prefer to know about the out-of-pocket cost of my treatment before I am treated, 79% of women agreed or strongly agreed. 40% of women agreed or strongly agreed that doctors should consider patient out-of-pocket costs when making medical decisions. Despite this, 24% of participants reported never knowing the total cost of their breast cancer care. Our study revealed many early and important findings about the financial burden of breast cancer care. First, over 35% of women reported significant financial burden related to their breast cancer treatment. Significant to catastrophic financial burden was more likely in younger minority women at lower income brackets. At-risk groups of women were disproportionately affected by the burden of cancer care. Second, even in this well-educated, engaged, well-insured population, costs of treatment were considered by 1/3 of women when making surgical treatment decisions, and became increasingly more important with declining annual household income. Thirdly, women prefer cost transparency prior to making cancer treatment decisions, yet this transparency remains poor. And lastly, out-of-pocket costs and risk of financial burden differ by surgical treatment type, despite having equally effective cancer outcomes among these common choices. Further research is needed to better understand if and how women might include cost information when making treatment decisions, to evaluate how physicians consider cost-informed decision-making, and determine the benefits and harm of potentially including treatment costs in decision-making process. Moving forward, it's important that we advocate for women with cancer and their families to improve the cost transparency and potentially reduce financial burden while improving quality of decision-making. Ideally, we will have the potential to improve patient-centered cancer care and overall health of our patients by aligning patient values and oncologist goals. I have many people to thank on my team, including my mentors, my patients, the Army of Women, and the Sisters Network of North Carolina, and those who support and fund my work. Thank you again for the opportunity to present today and for your time and attention, and I'd be happy to take any questions.
Thank you, Dr. Greenup. That was a great presentation. We're now going to take some questions. As a reminder, you can still submit questions through the questions pane in your attendee controls panel. So our first question, one of our members would like to know what the rationale for recruiting specifically for women instead of women and men in the study.
So that was a difficult, excuse me, that was a difficult choice. However, because I was very interested in looking at surgical treatment decisions, I wanted to limit it to women who potentially were eligible for lumpectomy with radiation, mastectomy with or without reconstruction, and even contralateral prophylactic mastectomy. And although many men with breast cancer are given the option of lumpectomy, it is still commonplace across the country, I would say, for kind of surgical dogma to be that male breast cancer is treated with mastectomy. So the surgical choice is probably less driven by patient preferences than it is for women with breast cancer.
All right. Were any breast cancer survivors eligible for this study, or was there a minimum or maximum time since diagnosis?
So we opened the study to any woman who had a prior history of breast cancer or a prior breast cancer diagnosis. And our breast cancer patients, there were women actively receiving treatment within a month of diagnosis, and we had people 36 to 37 years out from diagnosis. So although the median time from diagnosis was about 7 years, there was a very broad range.
I have a question. This is Susan Love. That it occurs to me that when the woman is sitting there with the doctor talking about what treatment option, they're in a one down, very scared position, and they may be scared to ask about costs that the physician may not like them as much or treat them as well, or think that they don't, that they're not, think badly of them in some way. And I just wonder whether you probed at all why they didn't ask.
So, excuse me, we did not dive into barriers to discussing cost of care in this survey specifically, because I hypothesized that women were not talking to their doctors about costs, and I was actually really surprised that 80% of women wanted to discuss costs. That's higher than what's been previously reported. So our next step is to put together focus groups of women who've had a breast cancer diagnosis to ask more about barriers to challenges behind, motivations behind discussing cost of care. Simultaneously, we've reached out to the American Society of Breast Surgeons and are in the final stages of revising a survey for surgeons to ask very similar questions. Because we don't really know what's holding patients and their doctors back from discussing this issue.
Yeah, I think that's good, because I think that, and I think in this country particularly, we're very reluctant to talk about price. The patient doesn't want the doctor not to like them, and the doctor doesn't want the patient not to like them. and so it'd be good to find out what the factors are and as a first step to figure out how to solve it.
I think it's a great comment and a really important point. And I think a lot of women don't, I think at the same time, I suspect that it's a time where money's not at the forefront of people's brains because they're really focused with their cancer diagnosis, understandably, and getting whatever treatment will maximize their survival.
And they don't want to feel like I'm not willing to pay,
right.
Or to make it look that way. I mean, so,
right.
Yeah, I think it's a really tricky situation, which obviously you can't study in healthcare systems that have government-run healthcare.
I think one of the interesting things about the United States healthcare system is that the transparency surrounding cancer treatment costs is poor, not only for patients undergoing treatment, but also for people working within the healthcare system. And most people who work in a hospital or receive cancer care don't really know ultimately what the final cost is. People know what they're charged, people know what they bill, but it's a very opaque system overall, which makes it far more challenging to talk about. With patients now absorbing more of the cost sharing and a higher percentage of deductibles, the out-of-pocket costs are going to probably continue to go up, and I suspect it will become a more important issue for our cancer patients as they're making decisions. But it's really important from my perspective that we start thinking about how this affects people after treatment and at what point they want to start talking about it, and who should know about it early, even if they don't ask, in order to avoid financial harm.
Yeah, no, I think it's a great area to explore and desperately needed. So good work.
Thank you.
We have another question from one of our users. This user wanted to know if you considered the fact that women may be unable to work during treatments, and wondering whether that led to greater financial stress.
So we do, it's an excellent point and a really important part of this story. I think the money is one piece of the puzzle. Having to pay bills for your medical treatment is obviously a huge burden, but there are many indirect and personal costs that women and their families absorb after diagnosis. We have questions within the survey that we are working on analyzing that look at kind of overall burden, days off work, and kind of how it affected the family for people to receive breast cancer treatment. At the same time, I'm rolling out a prospective survey, meaning women who are actively going treatment will be getting this in real time at different visits and different time points from diagnosis, because, for example, we don't have any idea how many hours breast cancer patients spend in the waiting room, for example, which is really a meaningful metric for the patients, but the healthcare system doesn't really acknowledge that. We don't really have a sense of how much people pay for parking, or how much childcare they have to get, or how many times they have to extend their short-term disability. And these might kind of what I coin as the burden of cancer care. These variables might actually be really meaningful at the time of decision making, especially when we are offering patients treatment options that are equally effective, so they're not compromising how well they will do by choosing one over the other.
All right, we have another question from a listener. She states that it sounds like there's a wide range of time since diagnosis. She was wondering if you noticed any difference between responses from people close to their diagnosis versus those who are 20, 30 years out.
So we haven't gotten to that data yet, but I suspect there will be differences because I think the cost sharing has increased in the last 5 years and the healthcare costs have risen. There's an issue with recall bias with any survey, meaning that participants have some difficulty remembering exact dollar amounts or exact dates. But we are going to look at that because I suspect that the burden has gone up over time based on the way healthcare has changed in the last decade.
Well, yeah, and also I think that acutely you think, oh, we'll figure out a way to manage it. And then later on you may realize that's easier said than done.
Right.
The cost.
Yep. And I think one of the really important components of the prospective survey we're working on is kind of understanding at which time point people have a true understanding of this burden. Kind of when does it become clear to them and start influencing their decision making. Mm-hmm. Again, shortly after diagnosis, many people are prioritizing their fear of recurrence and opinion and advice from the medical team, as my data supported. But again, I was surprised to see that even in this highly educated, overall well-insured population, that the cost of treatment became increasingly important for women as their household income fell. And I think that was surprising to me because there is a population that it really matters to.
Mm-hmm.
All right. Thank you so much, Dr. Greenup, for answering all these listener questions. If anyone has a question that we didn't get to today, or if you think of new questions, please feel free to contact us at connect@armyofwomen.org. We'll post a recording of this webinar on the Army of Women website in a few days. So on behalf of the Army of Women and Dr. Susan Love Research Foundation, thank you so much for joining us today, and have an amazing rest of your day.